Hello, everyone. I'm Margie Schofer with the Agency for Healthcare Research and Quality, otherwise known as AHRQ or AHRQ. And joining me today are Drs. Hardeep Singh and Annie Bradford, who are with the Baylor College of Medicine. And thank you all for joining us today to hear about a new resource we recently released called MeasureDX, a resource to identify, analyze, and learn from diagnostic safety events. So we're going to have a Q&A session at the end of the presentation, but please feel free to submit any questions you have via the chat as we proceed through the slides. Next slide, please. So before we start, I'd like to share with you a bit about AHRQ for those who may not be familiar with the agency. So AHRQ is an operating division under the U.S. Department of Health and Human Services, and our mission is to produce evidence to make healthcare safer, higher quality, more accessible, equitable, and affordable, and then to work within the U.S. Department of Health and Human Services and with other partners to make sure that evidence is understood and used. Now, I sit in the Center for Quality Improvement and Patient Safety, and we're responsible for the Making Healthcare Safer part of AHRQ's mission. And we improve patient safety by funding research to identify risks, hazards, and harms. And then we use that information to design, implement, disseminate, and spread and evaluate interventions to improve patient safety. And we also establish strategies to sustain patient safety improvements, such as patient safety culture, incident event reporting, measuring, monitoring, and surveillance. Next slide, please. So improving diagnostic safety and quality is an AHRQ priority. And we support the development of new diagnostic safety knowledge via grants and contracts. Now, we have a bunch of diagnostic safety related resources on the AHRQ website, and I've included a link on this slide to them. But right now, I'm just going to focus on our most recent resources. So we currently have a contract in place with MedStar and Baylor to develop several resources to improve diagnostic safety and quality. There are a series of papers on different diagnostic safety topics, some of which are issue briefs, and then some of which are published in peer-reviewed journals. And you can see a screenshot of just a few of these. There's many more on the website. We've also developed 3 different resources, and MeasureDX will be the focus of today's webinar. The 2 other resources are Team Steps for Diagnosis Improvement, which is our teamwork and communication training curriculum, specifically tailored to improve diagnosis in this case. And then we have the Toolkit for Engaging Patients to Improve Diagnostic Safety, which is focused on supporting providers and practice deep and reflective listening for 1 minute at the start of a patient encounter. And then we have one more tool that's going to be released in the fall called Calibrate DX, a resource to improve diagnostic decisions. And the goal of this resource is to improve clinician calibration, or the alignment between a person's diagnostic accuracy and their confidence in that accuracy. So I hope you'll stay tuned and pay attention for when that one comes out. So I am now going to turn this over to Hardeep and Annie.
Okay, thank you all for joining us this afternoon. My name is Andrea Bradford, and I'm at Baylor College of Medicine, where Dr. Singh and I have been leading the development of MeasureDX for the past couple of years. And we're excited to introduce this to you today. So for the next 20 minutes or so, I'm going to introduce this resource and walk you through how it can be used in your organization to help capture and learn from diagnostic safety events. And since you probably want to know where this resource comes from, I'm going to start by sharing some information about how we came to develop MeasureDX. And one thing I'd really like to emphasize is that even though it's just a small group of us talking today, this involved a team much larger than ourselves, including our partners at the MedStar Institute for Quality and Safety, as well as a number of subject matter experts that we consulted along the way. So I'd like you to think of this resource as a practical introduction to some work that's really leading edge, but at the same time, that's been road tested and used in real world healthcare settings. But first, a stark reminder of why we're doing this. An estimated 1 in 20 outpatients each year will experience a diagnostic error. And that's a staggering number of people when you extrapolate to the volume of patients that are seen in outpatient settings every year. In the inpatient setting, each year, it's estimated that 250,000 people will not only experience a diagnostic error in that setting, but will also incur some level of harm as a result. This is a huge problem. But the reality is that unless a missed diagnosis leads to a major event or a malpractice claim or a news story, it's likely to go undetected. And what that means is that the system really doesn't get an opportunity to learn from it or to act on that learning. And very few systematic strategies exist to detect and measure diagnostic safety. Up until now, most of those strategies that do exist have usually not gone very far beyond the academic medical centers where they were developed. The National Academy of Medicine recognizes this problem. In its 2015 report, Improving Diagnosis in Healthcare, recommends that payers and accrediting organizations start paying attention to this problem too. And there's every reason to believe that we're on the road towards payers and accrediting organizations looking at what healthcare organizations are doing in the service of improving diagnostic safety. How are they monitoring and learning from the events that happen within their own walls around vulnerabilities in the diagnostic process? Now, for reference, let's go ahead and get some terminology out of the way. AHRQ defines a diagnostic safety event in two main ways. One is probably the more familiar definition to most of us. It's the diagnosis wrong, was it delayed, or was it just simply missed altogether? The other important definition is if the diagnosis was made, but that information isn't conveyed appropriately or effectively to the patient or to the responsible family member of that patient, that also constitutes a diagnostic safety event according to this definition. Now, when we talk about measuring diagnostic safety events, we tend to have some preconceived ideas about what measurement has to be, what measurement needs to look like. So let's just very quickly go back to some fundamentals about measurement theory. Measurement is just the act of assigning some value or category to an event or object or piece of information. Assigning a category to a patient safety event is measurement, okay? But it's also just the beginning. You can go further down the line. You can break down a diagnostic safety event even further to get to information that you need. And the information that you need will really depend on your purpose. So we can use that information for quality and safety improvement. We can use it to benchmark or to track performance across organizations, across individuals. We can use it for research or public health applications. What we emphasize in measurement, how we carry that out, and what that whole process yields really depends on the purpose. The measurement for learning and improvement differs fundamentally from measurement for benchmarking or for research or for epidemiology. In safety measurement, we tend to focus on smaller, more narrow samples of events. For example, we might focus on a specific error-prone process because we know it to be error-prone. And so we're looking closely within that narrow band for evidence that there is a vulnerability or that something that we're doing to improve that process is working, right? Or we might look at a frequently missed diagnosis. We might look, for example, at diagnoses of pulmonary emboli or diagnoses of colorectal cancer. We might look within a narrow band because there's a particular interest in that area. We're generally more concerned in measurement of safety with depth than with breadth. So we're not necessarily trying to capture every single event that meets that definition, right? We want to know about events when we see a signal, or we want to know about safety events in the context of a process or a diagnosis that we know to be especially vulnerable. And we also want to know not just about clear-cut safety events, but also about all those near misses, the kind of weak signals out there things we would never use for accountability, but that might trigger us with putting on our safety improvement hats on to drill down and learn more about where there are vulnerabilities and opportunities for improvement. And we can feed that information into a continuous learning cycle where we identify what we might be able to improve, where we can make changes, we change things where we can, and we continue to observe and build momentum and learn more about what's going well and where we need to look more closely at vulnerabilities in the system. And most of you are here, I imagine, because you're thinking about how can I dive into this cycle? Where can you get started? As I mentioned before, others have already laid the groundwork, and we're translating some of the lessons learned from that previous work to a broader audience. Back in 2020, we surveyed and we summarized the state of the evidence in an issue brief that you can download on AHRQ's website right now. And what we found in this review of current strategies for safety measurement, for measurement of diagnostic safety specifically, was that some of these measurement strategies are still very much in the kind of research and development stage. They haven't really been tested in operational settings, but there are some strategies that have real proof of concept. That is, they've been applied in operational healthcare settings. They've yielded actual diagnostic safety intelligence on real patients in a real healthcare system. And we think that this subset of strategies is what's ready for prime time. And so after we created this operational measurement of diagnostic safety issue brief, our next initiative through AHRQ was to then translate this further and get these strategies into the hands of clinicians, patient safety professionals, and healthcare leaders. So we co-created Measure DX in very close collaboration with those very experts who had developed and initially tested some of these measurement approaches. In total, in the initial phase of development, we partnered with 12 experts who worked with us in small groups to co-create different sections of this resource, depending on their expertise and the types of measurement strategies that they themselves had developed and tried. So we divided up our experts into these small groups, and we each got together to brainstorm. Our team drafted content, showed it back to them. If you were going to communicate this to another healthcare system, is this capturing the important parts? Is this capturing the lessons learned that you would share with another healthcare organization who wanted to do the same things that you did? We took it back several times for more review and discussion so that we're really creating something that we felt captured what these experts, these early adopters or these innovators had developed, and getting it ready to share with other organizations. And as this resource came together as a whole, we brought in some additional patient safety experts, including a patient representative, and we reviewed and revised it some more. So there's been a lot of development and collaboration with multiple subject matter experts throughout the development. And then most recently, we've concluded pilot testing with 10 healthcare organizations. We asked them to take this resource, give it a try, and give us some feedback about how we can make this even better and more accessible. And so all of that work has gone into forming the finished version that has just been released that you can download on AHRQ's website. I'm going to briefly walk through Measure DX now. It's a written resource divided into 4 sections. The first addresses what's really needed to lay a foundation, how to make the case to measure diagnostic safety events and monitor diagnostic safety. Some tips and even a case example of kind of creating a coalition of stakeholders within an organization and building a team. And this can look like a very grassroots effort. This does not need or require a huge team from the outset. Some of that growth can happen organically, and that's okay, but you need to build at least a small team with the right expertise from the beginning, and make sure that you have the resources that you need in order to carry out the next steps. Now, the second section is a guide for actually assessing the resources that your organization has available to do this work, and also how to choose an approach, how to choose the next steps for applying measurement strategies that are actually a good fit and realistic with your organization's available resources. The third section describes how to use different strategies in order to detect possible diagnostic safety events using different kinds of data sources that your organization may have access to. I'll talk a little bit more about that in a moment. And finally, the fourth section gives some step-by-step guidance for reviewing potential events to confirm that there was a missed opportunity. So you might detect a signal using some data source that's available to you, but then you want to do a little more in-depth analysis to confirm that, yes, there was a diagnostic safety event, there was a missed opportunity, and also to extract meaningful information for learning and improvement when that does happen. The people who do this, as you can surmise, it's not just one. It's not just going to be one person. This is not the work of a single individual. This is a team effort requiring several different kinds of expertise. At a basic minimum, we recommend that the team consist of at least one clinician whose scope of practice includes diagnosis. You need someone who understands diagnosis and can lend their effort to looking more closely at the cases that you identify. We also recommend that your team include at least one quality and safety professional, someone who is well-versed in quality improvement methodologies and who can apply a quality and safety lens to this work in order to push any lessons learned forward and result in some kind of meaningful improvement in their system. So the team, at a minimum, should include these areas of expertise, but the team really should include everybody in the organization who has some stake or a passion for improving diagnostic safety, someone who can commit some kind of effort to the initiative. And that may be people like risk management professionals, system leaders where we can get their support, clinical leaders, unit leaders, really anyone who has the time and the interest and the willingness to dive in. The willingness and the motivation are really more important than expertise in diagnostic safety per se. Anyone who has a stake in the safety of the system should be involved in this team. But again, this can grow over time, and we don't want to give the impression that you need this enormous coalition before you can do anything. Quite the opposite. Some organizations will start very small, and that's perfectly okay. It's better to start small and to start where you are than to wait until things seem ideal or perfect. Once you've identified your team, the resource outlines ways to leverage 4 different types of data sources in order to identify potential safety events. And of course, you'll want to then analyze those further for learning opportunities. But how you decide to proceed with that event detection is going to depend on the capabilities of your organization and the data that's available to you. Most organizations can start by looking at data that they already routinely collect for other purposes. Things like mortality reviews or general quality and safety event reviews. The resource walks through how an organization can re-examine these data, maybe by looking a little bit further upstream in the diagnostic process to look at these events, applying a lens of diagnostic safety and learning more from them from that perspective. I'll talk a little bit more about that process of kind of breaking down and analyzing these events in a moment. But first, I want to walk through these other data sources that the resource suggests that organizations can consider for detecting these events in the first place. For instance, some organizations have a mature safety event reporting system, and that can be leveraged as a way of collecting safety data from frontline clinicians. Now, some organizations, and we highlight some examples in the resource, some organizations have taken an existing safety event reporting system and then modified it so that diagnostic safety is its own category of event. And you might give clinicians some specific but minimal prompts in order to solicit potential cases of a diagnostic error. Other organizations can even build a separate stream of collecting information specific to diagnostic safety events from clinicians. And the resource outlines both of those approaches with a real world example from each one. So having frontline clinicians provide this information or just alert the team to, maybe something, maybe there is a vulnerability, something wasn't right about this. And that triggers the team's further investigation. That's another strategy. And by the way, these don't need to be used in isolation. They can be used in combination with one another. So that's, if you do have an event reporting system, that's another potential data source for these events. Some organizations also collect information from patients. These could be things like complaints or incident reports, things that are often going through the risk management team, but they could also be patient experience surveys. If there are open-ended comments, for example, that identify concerns about diagnosis, this can also be a trigger for further investigation by your safety team. And again, the resource walks through a real-world example of how this could be used in conjunction with a routine patient experience survey. Finally, the resource provides some guidance for leveraging the capabilities of an electronic health record combined with a data warehouse that's able to be queried in order to use an algorithm to detect potential safety events from patterns of care that suggest that there may have been some breakdown in the diagnostic process. For example, this might be unexpected escalations of care, or it may be return visits to an emergency department. Those are just a couple of examples. The resource includes a table that outlines some of the potential algorithms that other organizations have already used and validated, although you're certainly not limited to these. A simpler means of extracting information from an electronic health record is just looking at all patients who may have had a particular error-prone or delay-prone diagnosis and reviewing all of the cases or a random sample of those cases within, say, the past year. But the idea is that you're letting the electronic health record and that capability along with your informatics team, you're using that in order to identify potential instances where there may have been a breakdown in the diagnostic process. And that could be through kind of proactively looking at something that you know to be error prone, or running an algorithm to look for unusual patterns of care that signal that there may be a safety improvement opportunity. So those are the four main strategies. And again, all of these come with case examples and citations of previous publications that describe the use of these strategies in real-world healthcare settings. All right. Once your team identifies these events, then the resource walks through, in part 4, a step-by-step process that includes the use of validated tools and instruments for determining whether a diagnostic safety event occurred. So the first the next step is to determine whether this really was a missed opportunity, and that requires some clinical judgment. So that's why clinical expertise on the team is really so crucial. That's one major reason why. And if there is evidence of a missed opportunity, then you have several options for further analyzing these events. And you could even report de-identified case details using the newly released common formats for diagnostic safety events. But you can use other types of analysis tools to identify where the breakdowns in care occurred and what may need to be done to fix those vulnerabilities in the system. So, for example, those of you who are familiar with this kind of work may be familiar with instruments such as the revised Safer DX instrument or the DEAR taxonomy. These types of systematic reviews will help ensure that you are applying a similar set of criteria to each event that you review. And this will enhance your reliability, but it may also streamline it so that you're really focusing your efforts on the most important information as you continue to gather your data. And of course, organizations that review multiple events can keep their own stores of data to look for trends and look for patterns in these events over time. Because this does require some clinical judgment, there's also often a necessity to train people, clinicians who would serve as reviewers for these events, who are really looking at the clinical details of a case and making that call as to whether there might have been an earlier opportunity to make a timely and accurate diagnosis. So the resource also includes some materials to help train clinician reviewers to use these tools and to do so in a way that's reliable. And again, the end goal of all of these activities is to extract meaningful information that can feed back to that system, that can inform interventions and priority areas, and even where you just need to continue your monitoring efforts over time. So the end goal is toward looking for those learning opportunities and informing those actions to change practices to improve diagnostic safety. As I mentioned a little while ago, we did complete field testing relatively recently with some organizations who took the resource, tried it out, and gave us some feedback about it. And what we found was that most of the organizations were able to use this, and most of them indicated that they would continue to use it in some capacity. And we got a lot of feedback, some of which went into improving and refining the final version that you can download today. But I wanted to highlight a couple of quotes it's not just about the data collection. It's also about giving organizations and teams some tips and strategies for making the case for why we need to do this and how to get started. And we heard from multiple field test organizations that building momentum is a really important part of this. It seems like a big lift in the beginning, and it is. It's an effort to do anything new, right? To create any new initiative. But once it starts in an area, you start to find these connections. You start to find these common threads. And several organizations gave us feedback like this, that once we got the ball rolling, then we started to see this through new eyes. And it's the effort began to build upon itself. And that's our hope for this. We want this to be a practical resource. Yes, it will require a little bit of a lift to get going, but our hope is to make that as feasible as possible for the most number of organizations. And again, I can't emphasize enough that perfect is the enemy of good here. You can start small and start with the data that you have available to you and go from there. And the resource is scalable to organizations that are ready to go out full force and use all of these measurement strategies, but it's also perfectly appropriate for those organizations who just want to start with one stream of information, one narrow band. Because again, when we're focusing on safety and learning for improvement, we can accept not having all of the information. We can start where we are, and that's better than where we were before.